Yeah, hi, my name's Steve Morris. I'm CEO of Arthritis South Australia, and I'm really pleased to have Professor Susanna Proudman join me, who's head of the Rheumatology Unit at the Royal Adelaide Hospital. Hi, Susanna.
Hi, Steve.
Hi, today we're just going to have a bit of a chat about scleroderma. So what is scleroderma, Susanna?
It's an autoimmune disease which is characterised by inflammation, like many autoimmune diseases, but also quite atypically for other diseases, there's a vascular component. So people might experience Raynaud's phenomenon, which is a colour change in their fingers or toes in the cold, often white, red, blue, and a condition called a component called fibrosis, which is due to deposition of collagen and other proteins in the skin, giving rise to thick, tough skin, which we call scleroderma. But these processes can also occur in other organs as well. So it is a multi-system disease of unknown cause, which has a wide range of manifestations, some of which can be quite devastating.
Yeah, no, absolutely. And how common is scleroderma in South Australia?
It's not one of the more common autoimmune diseases in the world generally. It is less common. It occurs in about 500-600 people in South Australia, about 6,000 people or so in Australia. But we know from some Australian work that the burden of this disease in terms of the cost to the health system, to the individual, is far greater than any of the other autoimmune diseases that we typically see.
Yeah. Okay. And you briefly talked about, obviously, the range of impacts. Are there different types of scleroderma?
Broadly speaking, there are two types of scleroderma based on the extent of skin involvement. So all patients with scleroderma start with Raynaud's phenomenon, as I described earlier, followed by puffy fingers, which is due to the early stages of the fibrosis or scleroderma stage. And that thickened skin slowly moves up from the fingers, up the limbs, sometimes onto the face, or even onto the trunk. And it's the extent of that skin involvement that defines the two subsets of scleroderma. So we talk broadly about the limited subset, where the skin thickening or scleroderma does not extend above the elbows or the knees, and it doesn't go onto the trunk, although it can affect the face and upper chest. And diffuse scleroderma, which extends beyond the elbows and knees and onto the trunk. It also occurs much more rapidly, and the organ involvements in the two subsets can be different as well. For example, lung and kidney disease is more common in the diffuse subset, whereas everybody with scleroderma, regardless of the subset, is likely to experience gastrointestinal involvement and run a similar risk of some of the more serious complications like pulmonary arterial hypertension. Limited scleroderma is about twice as common as diffuse scleroderma.
Yeah. You kind of mentioned that it was of unknown cause. Do we have an idea what may cause it? Is it related to genetics? Is it related to the kind of jobs people do?
We know that there are some genetic factors which drive susceptibility to this disease and possibly dictate what sorts of complications people experience. But it's unusual for it to run in families. In fact, it's very uncommon for it to occur in more than one individual in the family, although it does occur. Although other members may have other autoimmune diseases. So the risk factor seems to be for having autoimmune disease and not scleroderma specifically. There are some occupational risks described which may or may not apply to the vast majority of people in fact, but there certainly is an increased prevalence of scleroderma in people who work with silica. So traditionally that would have been in a sand mine. Nowadays, of course, we worry about those people who work with artificial stone compounds that are used to make kitchen benches and so on. The cutting process can release quite a lot of silica, and whilst increasing the risk of a serious lung disease called silicosis, we now recognise that it also increases the risk of scleroderma. So in recent times, we're starting to see the problem emerge again in young men who are often the ones working with these composite bench tops.
Yeah. Okay. Thank you. And you also talked about what some of the symptoms are. Are there common early signs and symptoms of scleroderma that people should be looking out for?
Yeah, so the most common thing that people experience is Raynaud's phenomenon, which is the colour change in the peripheries, in the toes, fingers, maybe the ears, nose, in response to cold, although stress and cigarette smoke can trigger it too. And that's a painful condition usually, whereby the colour of the skin changes usually initially to a dusky blue and then white. And then as the skin warms up, it may go red.
Yeah.
And this can be associated with signs of tissue damage, because these changes all reflect constriction of the blood vessels and reduced circulation to these peripheries. And sometimes it can lead to digital ulcers and other changes in the skin, which indicate that there's been a poor supply of blood. In fact, sometimes we can look closely at the little capillaries around the nail folds at the base of people's nails and show that the capillaries have changed, that some of them have dropped out completely because they've been so constricted in response to cold, and others have dilated in a compensatory way and become quite tortuous and abnormal in their appearance.
Yeah.
And then the next thing people might notice is the puffiness of their fingers, which reflects the early scleroderma, starting with an inflammatory phase, and then the thickness and tightening from the collagen that's being deposited in the tissues of the skin, a process we call fibrosis. People often have reflux. Gastroesophageal reflux is really common in this condition, but there can also be other gut symptoms as well, like diarrhea or constipation. And there are a number of much rarer but potentially serious gastrointestinal complications as well. And a number of people, particularly with the diffuse disease, develop interstitial lung disease, which is again a form of fibrosis or increased collagen deposition, but it's in the tissues of the lungs. Now, this is actually quite common in scleroderma, but probably only about 10% of people have clinically significant lung disease. And there are other organ symptoms that can affect the blood vessels in the lungs, the heart, and even the kidneys.
Yeah, so it's quite a complex range of symptoms and impacts. Can scleroderma be managed by a general practitioner, or will people need to see a specialist?
Typically, a person developing scleroderma does need to see a rheumatologist in order for the diagnosis to be made. A good history and examination is crucial to documenting the various disease manifestations and arranging certain blood tests to see whether autoantibodies have developed that can be associated with scleroderma. And there are different antibodies for different subsets too, which can be helpful in making the diagnosis. And over time, it is important for people to continue to see a rheumatologist for management of the various disease manifestations, and also to monitor for some of the more serious complications. But I think scleroderma is also a very good example of a disease where the multidisciplinary team is crucial. This is a long-standing, potentially life-threatening disease with multiple manifestations that can affect people in different ways. And not only do people have to see other types of doctors like cardiologists and respiratory physicians, gastroenterologists, allied health professionals, particularly those who can help people with some of the changes that happen with their hands. For example, contractures, like a claw-like appearance to the hand can occur sometimes. So hand therapists can be very helpful there in terms of reducing the contractures and reducing the disability that goes along with that. And of course, the GP is often in a good place to sort of help coordinate that and to ensure that all of these various members of the team are being engaged as appropriately and communicating appropriately, and to help the patient navigate all of these different resources.
You said that there's obviously a need for a rheumatologist to provide diagnosis. Are there any specialist centres in South Australia?
Yes, in about 2007, a number of rheumatologists around Australia got together and established the Australian Scleroderma Interest Group, and I was one of those rheumatologists back at that time. And in conjunction with interested cardiologists and respiratory physicians in a number of states, we established what we call ASIG centres in a number of cities around Australia. They're particularly strong, actually, in the southern states. So South Australia, WA, Victoria, Tasmania have very active ASIG centres. And we see many of our own patients who are referred to us by general practitioners and others. We also will see patients for other rheumatologists. So patients often continue to see their rheumatologists for their day-to-day management of scleroderma, and they come to our centres for annual assessment, particularly screening for some of the more serious complications, including the heart and lung complications I've mentioned.
Yeah. And in terms of what treatments are available, obviously you've discussed a range of symptoms. So are those treatments, in addition to therapy, or the medicines that are available for scleroderma that people take?
There have been very few therapies that have been proven to work in scleroderma until recently. The landscape has changed significantly in the drug therapy for this condition. Up till now, treatments have generally been targeted to specific disease features. So treatments for Raynaud's phenomenon, for example, include drugs like vasodilators. There are symptoms for treatments for gastroesophageal reflux, like proton pump inhibitors. And we have, over the years, used some immunosuppressive therapies for the lung disease and joint symptoms, for example, that arise sometimes. We also know that the renal disease, which occurs in about 2% of people with scleroderma, so it's rare but potentially life-threatening, responds now to a certain type of antihypertensive, a drug that's used for treating blood pressure, and that has significantly improved outcomes. So various treatments have come to light over the years that target individual complications. And they're not always drug treatments either. Obviously, for something like Raynaud's phenomenon, which is triggered by the cold, avoiding the cold, keeping warm, avoiding smoking, and so on is very useful. There are other things that people can do to reduce reflux, like having small meals, elevating the head of the bed, and so on. But in terms of medications for scleroderma, there have been a steady pipeline of clinical trials in the last 5 to 10 years of new therapies for scleroderma. And these have broadly been immunosuppressive therapies that we've already used in other autoimmune conditions, which are showing some benefit in scleroderma, particularly in relation to the lung disease, and new antifibrotic drugs, which we've never used in the past, but now there's the opportunity to use antifibrotic drugs for the lung disease, and others are in development for the skin and other disease manifestations. So the landscape for treating scleroderma has changed considerably in the last few years.
And that's good news. I think, obviously, it's such an impactful diagnosis. When people are diagnosed, is there anywhere they can go for, other than obviously talking to their doctor and other allied health professionals, is there anywhere people can go for support or further information?
Yes, there are patient support groups. Arthritis Australia has traditionally provided support for people with a range of autoimmune diseases, including scleroderma. So in your state, for example, in South Australia, that would be Arthritis SA. And we know that Arthritis SA has had an active lupus, scleroderma and Sjogren's support group for many, many years. There is now a scleroderma-specific support group called Scleroderma Australia, which has some state affiliates, but the national body generally supplies support for people in South Australia. So I think it is a case of asking around, talking to your treating doctors about support services that are available. There are some fantastic resources online offered by consumer organisations such as Scleroderma Australia, which can support people with scleroderma.
Yeah, and we'll provide details of those at the end of this podcast. So is there any final thing you'd like to say to those people that do have scleroderma, Susanna?
I think the key is to develop a relationship with a rheumatologist so that your disease can be assessed and managed appropriately over time. there are some serious complications, but they don't occur in everybody. And it is about being forewarned, I guess, and that gives you the opportunity to identify any complications if they develop, so they can be managed early, because there are treatments for many of these complications that do improve outcomes. So regular assessment is vital. And I'd also like to say thank you to all the people with scleroderma who've been coming to our ASIG centres all these years. They have been incredibly generous with their time and engagement with the ASIG programs, which have enabled us to collect considerable data about patients with scleroderma and learn so much more about the disease and the impact of this disease on the people who have it, the people who look after them, and the people who pay for it.
Yeah, absolutely. Well, thank you very much for taking part in this video cast, Susanna.
My pleasure. Thanks, Steve.